Hello, everyone. Good afternoon. For those of you that are on Central and Eastern time zones, we are so glad and thankful that you are here with us today. As everyone continues to get logged in and gets their audio set up on Zoom, we just want to take a minute to welcome everyone into the room. We know it's going to take a few minutes to get everyone in. And so while you are entering the space, we invite you to utilize the chat feature. You will see that on the bottom of your Zoom toolbar. Introduce yourself. Let us know who you are and what you do and where you work at. So you can engage with others that are on the webinar today as well. So we're going to wait just a couple minutes as people continue to get logged in to make sure everyone is with us. And while we do that, we do want to take a quick moment to thank our sponsors today. We do have the Great Lakes PTTC as well as the Ohio Program for Campus Safety and Mental Health. We could not do this webinar series without them this week. We are so grateful for their support. And so we encourage you to check them out. I'm going to put in to the chat feature their links, and I encourage you to check them out and please visit them. And we will put those links in at the end of the webinar again as well to make sure, because we know as people are introducing themselves, the chat is moving very fast, and so we want to make sure you have the opportunity to visit and thank our sponsors as well. So it looks like that we have everyone logged in, and so we are here. And so we're going to go ahead and get started. Briefly introduce myself. My name is Logan Davis. I work with the Higher Education Center as well as the College of Social Work at Ohio State University. And so we are super glad and excited to wrap up our week of what was supposed to be the in-person Ohio Prevention Conference. And so we are just excited that you hopefully have been with us for all 6 sessions. And so we are going to end it on a high note today, talking about suicide prevention in the state of Ohio. So the road, creating the road to wellness. And so we have Tony Coder with us today. So we're going to do his bio in just a few moments. But before we do that, we do have a few housekeeping items we would like to get to. We want to make sure that your experience today is valuable. And if you have any questions, we can get those answered at the end with our Q&A period. And so just to orient, if this is your first time with us utilizing Zoom, and so on the bottom, you will notice on your toolbar that you do have a Q&A button as well as a chat button. So if you have questions that you would like to ask Tony today, anytime throughout there, we will reserve 15 minutes at the end for questions, but you can submit those questions at any time throughout the presentation. And so we do ask that you utilize the Q&A for those questions that are placed in the chat. We cannot guarantee they will get answered as the chat continues to move, and that it's not easy to kind of identify those questions. So we do ask that you put those questions in the Q&A so we can ask those to Tony at the end. Continuing on with some other housekeeping items, we do want to let you know that this session is available for 1.25 continuing education credit hours. And so that is for social workers, counselors, prevention specialists, and chemical dependency counselors. In order to get the credit, you must participate in the full 60 minutes of the presentation, and then a knowledge check is going to be given at the end. And we want to make sure that you participate in that to receive your credit and receive your certificate. And those certificates will be mailed out or emailed out, at the end of the month, at the end of July. And so I did mention that this week was supposed to be the time that we were together celebrating community and the work that we do in the state. And our planning committee did a great job of planning that experience. And we were excited to host the U.S. Surgeon General. And unfortunately, he wasn't able to join us for the virtual experience. We know he's been a little bit busy, as you might expect, during the middle of a global pandemic, but he was kind enough to record some remarks for us. And so if you want to visit go.osu.edu/OPCSG, you can watch his remarks. They're about 8 minutes long, and they're very, very good. And so I do highly encourage you to watch those. And we're super thankful for him recording that in the midst of everything that is going on right now. And so with that, I want to turn it over to Valerie from Ohio Moss, and she's going to introduce Tony Coder to you. So thank you so much, everyone, and we are super excited that you're here today.
Thanks, Logan. Good afternoon, everybody. Thanks for taking the time and joining us virtually today. It's my pleasure to introduce my friend and colleague, Tony Coder, this afternoon. As Executive Director of the Ohio Suicide Prevention Foundation, Tony leads the charge to support community-based efforts in Ohio to reduce the stigma of suicide, promote education and awareness about suicide prevention, provide training and development, and increase resources and programs that reduce the risk of lives lost to suicide. Prior to OSPF, Tony served as the Director of Programs and Services for the Ohio Association of County Behavioral Health Authorities, where he managed recovery-oriented systems of care, the statewide advocacy network, and the committee to address suicide for the organization. He has also served as the Director of State and Local Affairs for Smart Approaches to Marijuana and as a Legislative Director for the Ohio Department of Jobs and Family Services. And through everything Tony does, we always know he has a lens of humor, which we greatly appreciate due to the heavy work that we are all engaged in. And we appreciate his leadership in this space. So with that, I pass it over to Tony. Thank you, Tony.
Thank you so much, Valerie, for those kind words, although I really have to shorten up my bio. Good Lord, that is a long bunch of nothing. So, but thank you so much for that. So today we are talking about suicide, what's going on in the state of Ohio, how we are going to look at the state over the next couple of years, some strategies we're going to be working on. Just wanted to, before every presentation I give around this subject, wanted to just share with you some, presentation decorum. This is not an easy subject for some folks. If you feel that you need to leave, if something's triggering, if we're talking about something that is too upsetting, my feelings, I will never know. So my feelings will not be hurt at all. I encourage you to take care of yourself and to make sure that you have your own self as priority here. Questions, if they're, as the questions come about, I'll do my best to answer questions. I'm not a therapist, nor am I a clinician. So if you ask specific questions about DBT or CBT or something really philosophical in nature, I can only give opinion to some things. I usually get asked religious questions and those types of things. And I will preface this is an opinion only and not based on any kind of fact or anything. If some philosophical question comes up. Assume good intentions. If there are questions in the chat, in the Q&A section. I know that the phrase that we used to use was commit suicide, and that is not used anymore. It can be taken as an offense. So we use die by suicide. If someone does say commit suicide or some other expression, let's assume good intentions. No one's here because they are trying to break in on this webinar and ruin it. We're all trying to learn from one another and be, I really would like for us to be cognizant of that. Also, if you or someone is having suicidal thoughts, please call the National Suicide Prevention Lifeline, which is the number listed there, 1-800-273-8255. And in about 2 years, we should be getting the 988 number as well. So they're going to vote on that, changing the suicide lifeline over from that long number to a 988 number. They vote on that July 16th, I think, the FCC does. So OSPF, really quick overview about what we do, the Ohio Suicide Prevention Foundation. We provide suicide prevention resources, education, training, advocacy, evidence-based programming. We work closely with the department and with Valerie on evidence-based programming for communities across the state. We take campaigns and content. We are currently reviving the Be Present campaign, which we're really, really excited about with the department. That should be happening in the fall. That is a peer-to-peer program. We also work with statewide coalitions and local support. So we work with, I think there are somewhere around 70 coalitions in the state of Ohio, suicide prevention coalitions. We also work with a number of veterans groups and just other community groups that want to know more about suicide. We were actually contacted this week by the Ohio Railroad Association. So, we even work with those folks as they're trying to figure out some strategies to use in their work. And this is just a list of our training. You can review this if you would like to go back and watch this again. This is just a number of the trainings and resources that we have from our organization. I'd like to start off with a poll question very quickly. So what demographic makes up most of the suicides, the number of suicides in Ohio? Is it teens, college age and young adults, middle-aged adults, or older adults? So let you take a moment to answer that. So who makes up most of the suicides? What age group? Patrice, you're right on top of it. In the chat box there, I see one of her. I see one of Patrice's chat, and Patrice is exactly right. Middle-aged adults, usually middle-aged men, 35 to 65, are the folks who die by suicide the most. A lot of times when I go talk to legislators or other groups, everyone thinks it's a teen issue. And actually, middle-aged, especially middle-aged men, trying to take us back here, actually they make up around 78% of all the suicides in the state of Ohio. Now, that doesn't mean that we don't have an issue with youth suicide in the state. In fact, suicide is the second leading cause of death in young people, ages 10 to 24. And sadly, it's the leading cause of death in youth ages 10 to 14. Now, there's not a great number of young people, but because, young people don't usually pass away so early, it is something to think about there. The other thing that we're really, really concerned about is the fastest growing suicide rate is among Black non-Hispanic males in the state of Ohio. Those suicides have increased nearly 54% over the last 4 or 5 years. And suicide also makes up about 65% of all of the violent deaths in the state. So, a lot of times we'll think about murder or things like that. And it really, suicide's an issue. It's an unspoken about issue. A lot of times people will almost back away when I start talking about it or when you start talking about it. So it's something that is, makes a lot of folks uncomfortable. So I'm glad you're here today and that, you're able to take part in this webinar. Most people do die by suicide using a firearm. Firearm is the number one reason or the number one way that folks do die by suicide. Doesn't mean that we are anti-gun. We do not take any kind of stance on guns at Ohio Suicide Prevention Foundation. Instead, we try to work with gun owners. We try to work with gun shops. In fact, the University of Washington did a study and that showed in July of last year that gun shops can play a pretty significant role in suicide prevention. So, having the number at the Suicide Prevention Lifeline at the counter, training them in QPR, which is a suicide awareness and a way to recognize suicide. So it's the signs and symptoms. So we don't get into gun control debates at all, just like we don't get into opiate debates or anything like that. We want to, at the end of the day, meet the person where they're at and actually try to save a life. We do encourage folks who might have guns in the home, if you're feeling depressed, if you're feeling anxious, if you're having suicidal thoughts, to maybe work with your neighbor, or hand your guns over to someone for a short time. Doesn't mean we take anybody takes them away. You make that decision about when you need to get those out of the house. Also, we do encourage, because young people die by suicide by firearm, that you lock your guns. You lock your firearms up as well. When you're not using them, when you're not hunting or doing what you want to do. So it's it's a touchy debate. Even when I say we don't take a stance on guns, we usually get some angst from either side, and I have had folks walk out because it sounds like we're anti-gun. We're not anti-gun. We're just trying to save lives and give folks some options around guns and suicide. So youth suicide, again, we mentioned it's not a whole lot of folks. It's about 187 out of the 1,836 folks who die by suicide in the state. And we're about average compared to other states. We don't have, a great, a bigger number than other states. We're about right in the middle. In fact, nationally, I think we're 27th as far as suicide as a state in the country. And again, we go through these, this is a youth issue. It isn't, necessarily a youth issue, but we do need to make sure that we are getting to young people, younger and younger. In fact, there was a good article the other day about that Nationwide Children's was a part of, about suicide and being taught, even in suicide prevention being taught in elementary schools. We know that PACS, the good behavior game, is a good intervention for all young people, building those resiliency skills and the protective factors. So we are encouraging that folks get young people get younger or get educated younger and younger about mental health and about suicide. So that they can have that conversation if they ever, experience those feelings. Most young people do die by suicide, usually by hanging or strangulation. But, there are about 40% of the kids do use firearms as well. Suicide attempts. This is a really, really difficult subject because we don't have a whole lot of great data about it in the country. In fact, these are all national statistics that we're looking at right now on this slide. There's a lot about self-harm and those types of things. The 2017 YRBS survey does ask questions around suicide, and it shows that about a little over 7% of youth reported they had made at least one suicide attempt in the last year. So that's pretty troubling when you think about 7 or 8% of the kids who have made that attempt. And I've been to a number, sadly, of youth suicide funerals in the last year. And they're always devastating. It doesn't just end with that child or that family who's experienced that great loss. It impacts an entire school, an entire community. So, it is something that we really need to make sure that we pay attention to and look at. The other issue about suicide attempts, we talked how many males are actually completing suicide, but suicide attempts, female youth actually attempt about twice as much as males do. However, males have the higher suicide rate, suicide completion rate. Why is that? Again, it goes back to the way that they die by suicide. Firearms are involved more in young men than young women. Again, we have to make sure that we are being culturally competent. We have to make sure that we're going into urban communities as well, because we are continuing to see the suicide data pointing toward African Americans and Hispanic youth. We need to make sure that we invest in those communities, and we cannot forget about those young people, because for years it's been thought of as this kind of a suburb or Caucasian issue. And again, we're seeing more and more young Black youth dying by suicide. We need to make sure that we are developing strategies and that we are getting into communities that are underserved in this state. If you have any questions, please. I'll run out of breath here if you don't. So the other issue, suicide is, it's tied into mental health usually by folks, and that is that's normally the case. That 55% of folks who died by suicide had a current diagnosable mental health problem, and it's been estimated that 90% of folks who died by suicide had an either diagnosed or undiagnosed mental health issue, whether that's depression or suicide or schizoaffective disorder or whatever else, that there's some kind of mental health issue going on with that person, whether it's been diagnosed or not. Again, we can see that, and this kind of tells to the stigma, especially around males and mental health, that the higher number, do I think that more females have mental health issues? No. It's a diagnosable, they've been diagnosed with one. They went to a provider for mental health treatment, a counselor, something like that. And males just don't do that. Right. We hope to change that conversation. We hope that through our work that we can see that folks are not, that males also, that they get that help as well. I worked with Congressman Patrick Kennedy for a bit at SAM, Smart Approaches to Marijuana. And the one thing he talked about mental health parity. And he said the hardest thing, it took him 17 years to pass, he and his father, Ted Kennedy, to pass the mental health parity bill. And he said, you know why it took me 17 years to pass that? He said, because I had to convince Congress that the brain was part of the body. When we, if we think of, the brain or mental health, we almost think of it as outside of physical health. But we need to make sure that these are closely tied together. If you have a broken arm, you automatically go to the doctor. But if you have a mental health issue, then, especially males, you kind of back away from that. Oh, I need to be stronger, that type of stuff. And that's not the case at all. We need to make sure that we are fit as a fiddle in all aspects of our health. And, we are really, really hoping that we can change that conversation. So let's go to the second poll question. So because alcohol is a legal drug, we know that alcohol is found in people with the most frequency of those who die by suicide. But what is the second? It should say, so outside of alcohol, what is the most common drug found in a person who has died by suicide? Is it opiates, marijuana, benzodiazepines, or cocaine? And this is in the state of Ohio. Windows is continuously improving. So a lot of folks say opiates, and actually it's benzodiazepines. That's the second most prevalent drug in the system of someone who has died by suicide. And that's mostly driven by females. Females have they have much more of a benzodiazepine in their system than males do. Interestingly enough. And as we look at this next slide, we can see that, it still isn't much. Only 20, 27, 28% of folks who die by suicide in the state of Ohio have alcohol in their system, which is, quite frankly, low. Now, the issue lies, we'll look at this in a slide in a minute, is how much alcohol is in their system. But you can see benzodiazepines, and then that's followed up by opiates, antidepressants, marijuana, cocaine, and then as you can see down at the bottom, 65%, one or more of the above substances. So, they, as a majority, they do have something in their system, but, it's a number, it's kind of a smattering of substances that folks can have in their system when they die by suicide. I don't ever want anyone also to think that, I'm blaming alcohol or, for suicide or anything like that. I do think that when we look at, the amount of alcohol in a person, in fact, let me go to the next slide and then I'll go back. You can see that, if it's less than 0.04 and, 0.08, you can be, legally drunk. But when you hit this 0.20 and above, you can see that rate just really increase. So, to drink large amounts of alcohol, almost, and when I was in college, we would call it liquid courage. It would help you get, get enough guts to ask whoever else you wanted to go out on a date with and things like that. Does it also sadly provide liquid courage to, take your own life or cause depressive states that, since alcohol is a depressant. So, it's really interesting that 0.20 and above, it really skyrockets. Suicide does. Now, going back to the slide around opiates and suicide, this is an interesting slide. In fact, Valerie is part of a group that we have just formed along with the Board Association, some coroners, Department of Health, and some other folks, managed care companies, to look at the issue of opiates and suicide. They are both deaths of despair. That's what they're labeled as. However, if we can perhaps figure out to a little better degree of how many people are intentionally dying by overdose or accidentally dying by overdose, it might be able to change some conversation about what else is needed around opiates and around overdoses. Right now, there's not a whole lot of great data out there that is available. Nora Volkow, who is the director of the National Institute on Drug Abuse, her quote's over here. Likely 20 to 30% of opiate overdoses are suicides, but it could be higher. That's just an estimate that she made. And also, as you look at this, it could also help us understand how to develop strategies around men and women. Women with an opioid use disorder were 8 times as likely to fall victim to suicide, whereas men were only twice as likely to die by suicide if you had an opioid use disorder. So, this especially affects women, and it is something that we are going to take a better look at as a state of Ohio and develop strategies there. Could this be, we always think of Narcan, and absolutely naloxone or Narcan is absolutely crucial to saving folks' lives. But, does there need to be mental health assessments being done? Do we need to encourage mental health treatment? Are we asking the questions about, living or, purposely trying to take your life, or even apathy to life, which is, kind of this gray area of, if I die, I die. If I live, I live. I just want to take my pain away. And that's the other thing about suicide. The majority of folks who die by suicide, they have had suicide attempts. They say, we don't want to die. We just want the pain to go away. We just want to stop hurting. So it's not like these folks want to die. And my son, the reason I'm in this work, going from mostly a political type of career to this, my son had a suicide attempt back in 2017. And he didn't, he still says, I don't want to die, I just don't want to hurt anymore. And, he was diagnosed bipolar, and he was sick of feeling this way in his head, and not understanding his highs and his lows and all of those issues that he was dealing with. And even the medication that he was on, that he is on, it still makes him feel like a little bit less than what he did when he was not on medication. He said, he tells me, Dad, if I, when I was off medication, I could feel things. Yes, I felt the lows, but I also felt these extreme highs. And this kind of evens me out. And that's troubling to him, which I find kind of interesting. So, looking at opiates and suicide, we hope to develop some good data around this and be able to treat this problem holistically, as opposed to just a drug issue or just an opiate issue, and more than just treatment around opiates like Narcan. And instead, how can we holistically help this person, survive opiates and get help. That slide. So we were the only state in the nation, Ohio was, to not have a suicide prevention plan in the entire country. And talking to Valerie at the department, and Director Chris, and some folks in the governor's office, some folks at Department of Health, we decided to convene a group of folks to develop a comprehensive state suicide prevention plan for Ohio. And it was released, I think, literally before the shutdown, 2 weeks before the COVID shutdown. Governor DeWine was at Dayton Children's Hospitals, helped us and led that release to the public. We're starting to look at how we can actually implement some of these strategies, especially in these strange days that we're in right now. The planning team that went into this, it wasn't something that Ohio Suicide Prevention Foundation, we would have had that could have done alone. I mean, it would have been an absolute horrible plan. It would not have gotten any of the depth that the current plan has. So the governor's office, Valerie and Stacy and Bobby from Ohio NOS, all were on this committee. Department of Health, Department of Aging, looking at those adults, making sure that, isolation's a big deal around suicide, and helping folks feel connected to other human beings. So these are the groups that came together to develop the plan. And we, it took us, I think our first meeting was in August, and it took us a good, 8 months to 6 months to actually release the plan, a number of meetings, a lot of discussions, some of them even uncomfortable. But the thing that was so beautiful about it is no matter how opinions were, we came to what was best for Ohio. We thought outside of our organization, outside of ourselves, and instead we went to what is best for the state of Ohio. So with the plan, the vision statement, we talked a lot about, what should we have the vision statement? What is our goal? What's our ultimate goal here? And this is a plan that is for 2020 to 2022. So December 31st of 2022, we hope to be releasing a report and showing the measurements of how we have done in implementing this plan. And we went, 10%, 20%, how much could we reduce suicide? And, it finally came that, what is an acceptable number of suicides? What were we willing as a state to say, you know what, this is an acceptable amount of people who die by suicide, who kill themselves. And it finally came to the point, and I'm sure Valerie remembers that day, quite vividly, because it was quite a spirited conversation, that Ohio reduced the number of suicides every year until not one life is lost. We have to understand and we have to value every life, and we can't stop. We can't be satisfied and celebrate in 2 years if we drop the suicide rate by 20%. For those, for those families who lost somebody, that's not anything to celebrate. Until we actually can see this through to not one life is lost, we can't be done with what we're doing as a state. And, the core assumptions, we came up with some core assumptions. And, number one, right out of the gate, suicide is a preventable public health problem. This is not a moral issue. This is not a religious issue. This is not an issue that just lies for those who have, diagnosed mental health conditions or anything else. This is a public health problem that we need to take action on. So, looking at it from that public health approach, especially on the prevention side, looking at the universal, the selected, the indicated prevention, taking those folks that we could identify through surveys or through assessments as elevated suicide risk, making sure that they get, that we intervene with them and we help them get to competent care. We also know we have to really work on those barriers, whether that's access to care, whether that is ability to even get there, transportation issues. Telehealth has been helpful. I know it's not the preferred means of some when all of this first started, but we've seen to manage, and it's actually increased ability for folks in other communities to, in communities that normally aren't served, and I'm talking about Southeast Ohio a lot, that don't have, certified psychologists or psychiatrists. And, with telehealth, we're able to reach those folks. Now we've got to get internet down there, which we have weighed in on a bill to try to expand internet in the state, which is interesting. We have to make sure that postvention is also an important part, a vital part. That postvention is prevention. We know that folks who, if they have a loved one who dies by suicide, then their risk of dying by suicide themselves automatically goes up, just because of the grief and all of the issues that surrounds that loss for that person. So we need to make sure that we have good postvention care for folks after a suicide, and because we know that, again, postvention can be and is a good prevention strategy. We also, one of the things that we wanted to make sure, throughout this entire plan, and it led to some pretty colorful conversations, we need to stick to data. There's a lot of, again, a lot of folks, when they think suicide, they think of young people. But the data shows that, the majority of folks are, middle-aged people, especially men. How are we reaching them? Do we have a whole lot? And quite frankly, there's not a whole lot of folks who are, or there's not a whole lot of programs out there for middle-aged men out there, and especially when you get into the urban communities. We have a program called Man Therapy, which is this, we can talk a little bit about later, but it's not for every person either. A lot of folks don't like it. It does have evidence behind it, but it's still, we need to develop those strategies to get into every community. So, we can read on, and in the interest of time, you can go over those. Stigma is another big issue. That's still, there was an article in the New York Times yesterday. We posted it on our Facebook page today about veterans, and especially if you're in special forces, elite forces, SEAL teams, those types of things, you don't talk about mental health. If you're having an issue with your mental health, you don't talk about that. And it was a pretty robust article around how stigma is influencing issues within the military and special forces. And that's just not the military, that's everywhere. Again, we go back to that slide about, males getting, adequate mental health care. It just is something that we're still lagging, and we still need to bust through that wall. So the plan priorities were basically that we wanted to make sure that we got primary prevention, that we needed gatekeeper training, some campaigns, the PACS Good Behavior game. We needed to make sure that, before they got to that point where they were considering suicide, that we built that resiliency in young people and in people in general, that we have good public awareness campaigns that, wow, maybe I'm starting to feel, maybe my depression maybe I've got depression, maybe I have anxiety. Having those types of awareness campaigns, and then also just general gatekeeper training. We have a training called QPR, which is free to, any community that would want it. And it's basically the signs and symptoms of suicide and, how to talk to somebody about suicide and get them referred to help. QPR stands for question, persuade, and refer. Jamie Belcher, thank you. She's a trained QPR gatekeeper. So, there's a number of folks out there. So if you don't have that in your community, if you've not heard of that, again, it's for the average Joe. It's for the, anybody could be there just to learn a little bit more about suicide and be able to take part in those conversations. Plus, it's usually an hour or two long. So it's not like an entire day has to be spent. It can be done in an evening or an afternoon. We also need to take a look at high impact systems, which we'll look at later. Build capacity. Capacity is still something, coalitions, state entities, providers. We need to build that capacity to take care of people who are experiencing, suicidal thoughts and ideations. We also wanted to look at high-risk populations. This is where most of the colorful conversation took part, but we had to always go back to our data to come up. We want, it was hard because everybody's important, and we absolutely realized that. But there's also, if it was everyone, then, how can we make sure that folks who are being hit by this the hardest actually get care, in a timely fashion? And again, goes back to data. So strategy one, it goes, kind of goes back to that campaign. I won't spend a whole lot of time on this. We're going to recognize the warning signs of suicide and risk factors. So we want to make sure that the public's knowledge, more folks know about suicide. It's kind of amazing. I can't even go to a Starbucks if someone asks me what I do. Everyone seems to have a story. And it's usually when, I went to a Starbucks a few weeks ago, and, just opening up and, had my little mask on, and they had their little mask on. And, they asked me what I did for a living, and I told them, and, and they told me about this sister who died by suicide. And we did it in hushed tones, which is harder with masks. But, this is something that there's a lot of folks suffering or thinking about this issue or wanting to talk about it. They just don't know how. And we just, it's such a touchy subject, and folks are nervous to look at this. That, we need to make sure that folks are comfortable, because, research continues to show that, asking someone, in a conversation, if you think that they're going to kill themselves or thinking about killing themselves, asking them that question is actually useful. It actually relieves burden from that person and allows them to talk about it. And then you're able to help them or get them to care. The other piece of this is, again, encouraging safe storage of firearms, safe storage of medication, other lethal means that we have. So, we are beginning to work on some of these public awareness campaigns, and coalitions across the state have been working with firearms dealers, and we need to make sure that we get those public awareness campaigns out there even more. Strategy 2, we talked about hitting the, so this is the systems care. Where are folks at around, who are dying by suicide? What are they doing? Where are they going? Before they ultimately take their life. Well, we know that data is showing that healthcare, behavioral healthcare, we need to make sure that suicide care is integrated into obviously the behavioral healthcare facilities, but also physical healthcare, our hospitals, our physicians' offices, all of those types of organizations. We need to make sure that we provide training to clinical and social service providers on suicide prevention. A lot of schools, a lot of universities do not have a suicide prevention as part of their care, for even folks who are clinicians. So we, provide CAMS and AMSR, a couple of suicide-specific trainings for those clinicians who want to, who are working with someone who is suicidal. And we also need to get into ESCs, schools, all the different systems where folks are really impacted the most, or it could have the most impact in reaching the greatest number of people who are thinking about suicide. And this brings us to our third question. What percentage of people who die by suicide visit a hospital or their primary care provider, so a physical healthcare facility, within a month of suicide? So what percentage of folks? It's actually around, most folks said about 25%. It's actually around 50%. It's nearly half of all people visit their an emergency room or their physical healthcare provider, their primary provider, within a month of dying by suicide. So, what does that tell us? Do we need to do better screenings? Do we need to make sure that we assess folks who are in there? Looking at some, very, very early data from managed care companies, they have done some, what were people in for? Looking at, why did people go into the hospital in the first place, or their primary care provider? And we look at things like, well, hypertension was a big issue of folks. High blood pressure. So there were some physical signs that they were under some kind of stress. How can we make sure that physical healthcare provider actually, give a good assessment and talk with that person about suicide, and about being referred to someone who is able to help that individual. So that's a pretty interesting piece. The other thing that really drives this is the Joint Commission, which is an accrediting body of hospitals around the country, actually put a national patient safety goals into effect on July 1st of last year. And basically it is zero, it's a program called Zero Suicide. So it's, better assessments and, more opportunity to assess a patient around suicide. It's to actually also build what's called a safety plan, which with a patient who might, who's you think might be suicidal. So it's, those, who are the 3 people you can call at any time that would be able to talk to you? What are the things that you could be doing, to help clear your mind? Is it exercise? Is it reading? Is it something else? And there are quite frankly, a number of apps that do that. I know that the number one used one is something called My3, which is, again, you put your 3 folks in who you can call anytime, day and night, when you're feeling suicidal, and that person will talk to you and help you get some care. The other piece that we're really finding some success with in our work with Nationwide Children's Hospital is aftercare, what's called caring contacts. And literally it is so easy that it's kind of unbelievable. It's simply sending a text message to kids who have been in to the emergency room or the behavioral health clinic for suicidal thoughts or depression. Sending them a text message has had a great impact on these young people. The VA does it, so Veterans Administration does it through sending postcards. So they're sending their patients postcards for the mail. Again, it's shown some great success. How could we in our coalitions be helping to send some of those things or to weigh in on providing some aftercare, without also, you got to worry about HIPAA and patient confidentiality, but how can we do a better job of that? That's a lot of what Zero Suicide is. So we're looking at those types of trainings. Strategy 3, how do we build those groups? How do we make sure that our coalitions are fed with good information, evidence-based strategies, enough funding to make sure that they're able to do work in their local communities? I'll be honest, I don't do OSPF, Ohio Suicide Prevention Foundation. We can't do suicide prevention unless folks at the local level. The local level folks are the ones doing the work. We understand that. We are here for you. We are here for anybody who is at the local level, who wants to grow, who wants to know and be a difference maker for suicide prevention. Let us help you provide those tools. Let us help you, because you are doing the work. You are the champions on the front line, the local communities, and we just value what you are doing. One of the things I'm really excited about through Valerie's leadership and Stacy and Bobby at the department is, our number of suicide prevention coalitions who are aligning with the CDC 7 strategies for preventing suicide. We're taking coalitions. We're working with Ohio University and the George Voinovich School to really do some work around getting those 7 strategies in practice at the local coalition level. And then also, how can we also look at fatality review boards? We discussed creating separate suicide fatality review boards, but after talking to the coroners, how do we look at this holistically? Again, going back to that opiate issue that we had, how can we look at this as a system and as a whole, as opposed to just looking at in one silo suicide, one silo opiates, one silo whatever other kind of death review boards are that? How can we put suicide in those already existing fatality review boards? And then again, how can we build the capacities to overcome those barriers to care and other factors that contribute to the suicide rate? Strategy 4 is, this is all based on data. Who are the folks who are dying by suicide, the most? Or in the case of young people, it's their number 1 or number 2 reason they're dying. Is suicide. So we know that, again, we've talked about males, adults, young people, veterans. And then also, if you look at the map there, you can see that the highest rates of suicide are folks in Appalachia. That's something we need to look at. How are we able to provide better care for folks down there? And pray to God that this doesn't restart. But how can we make sure? Because it's really quite stunning to see that map and to see how many counties are actually struggling with high suicide rates. Other thing that we wanted to make sure of, however, is that the community, they look at their own data and they're able to identify their priority populations. An example is in Franklin County. on the east side of Franklin County, there's a very high Nepali population. Well, obviously throughout the state of Ohio, that's not a big population. But when you look at Franklin County, when you look at Reynoldsburg and Whitehall and Pickerington, you see, a pretty large number of Nepali citizens, and they're struggling with suicide, and they're not talking about it as well. It's it's a big stigma in that community from the folks in the Nepali community that I've spoken to. So we have to make sure that, as we have done this as a state, you also do it at the local level and identify who your greatest populations are that are dying by suicide. Again, veterans, we talk, 2022 veterans, that number, it was at 22, then it went to 20. This year it's at 21 veterans die every day by suicide in the United States. So it's it's kind of a moving number, but it's around 20 to 22 that we've seen. Veterans make up 18.5% of our national suicide deaths. And we in Ohio have the 5th highest veteran population in the entire country. We need to take care of those who have served, who serve our country and have done, such admirable jobs and serves so, with such valor, that we need to make sure that we take care of them as well. And folks are struggling. And then 5, again, goes back to data. That everything we do has to come back to data. We have to improve those data systems. I'm very, very excited. It's not ready yet, but the Ohio Department of Health got a grant from the CDC that would install a syndromic surveillance system around suicide, which would basically be almost real-time data about suicide attempts going into hospital rooms. So, if you're a community leader, if you are a board director, you'll be able to see that data. You'll be able to access that and see, wow, we've had 5 suicide attempts in Akron, Ohio. Why is that? And help you make some decisions about, doing a public awareness campaign or working with providers or asking, creating a plan to deal with folks who, might be having more suicidal thoughts in the community. And, it would be remiss for me to not talk about COVID. And, everybody says, oh, I get calls from legislators from both the federal and the state level. What's going on? What's going to happen? Are we going to see more suicides around, because of COVID? And, my answer has to be, we don't know. We've never been through this. The last pandemic was what, 1918? I've seen one study on it. They just didn't look at suicide. Suicide prevention is a really, really early field. It's somewhat of a new field. And I'm talking the last, 40, 50 years as opposed to physical medicine. So, we just don't have a whole lot of data about what is, how to handle this. We do know, if you look at some of the factors in suicide, the increased isolation, isolation is absolutely a factor in suicide. Feeling stress about health, about your financial situation, even the political arguments, getting, social media, there's a lot to be said for, good about social media, but, there's some things that sometimes I want to turn the old Facebook off because it causes so much stress. Anxiety, there's anxiety, if you're already someone who is suffering from anxiety, and, we're talking about reopening restaurants and schools and even the pandemic itself, that really, can increase anxiety among folks. And even if you don't have anxiety, that's, I'm going to lunch with somebody tomorrow, and I am honestly a bit nervous about it. I've been to one lunch since March. So to have that feeling of, oh my gosh, what is this going to be like? And, the glass is going to be clean, and we're going to sit outside and all that kind of stuff. But it really is, a lot of anxiety around this entire issue, and we just, again, we've not been through this, so how do we handle it well? Some stats that 1/3 of Americans report, this is May of 2020 release of the census data, clinically significant symptoms of anxiety. It's 33%. I think some of the stats I've read is 1 in 5 folks have a diagnosed mental health condition. When you're talking about 1/3 reporting clinically significant symptoms of anxiety or clinical depression, that's really, somewhat frightening. And in a system that's already, we don't have enough folks who are, able to meet those needs. The other, I also found this around COVID. There's a study done by Wellbeing Trust, and they took into account all of these different things around suicide. And they estimated that COVID may lead to anywhere from 27,000 to 154,000 additional US deaths over the next decade. So this is 2020 to 2029. And why is that number so large? Well, it kind of boils down to unemployment. They think the number is going to be somewhere around 75,000, but it's if it's a slow recovery or it's a fast recovery. And, I'm not saying, I'm absolutely, I wear the mask, and I want to make sure that we are kept safe. Also, however, we are, nervous about, as we see the increases in unemployment, and that we are going to, probably see more suicides in Ohio. And, the other thing about COVID, we aren't seeing suicides happening now they're about the same as they were the last couple of years, the same numbers. We're looking at, and we with the department and some other folks are looking at a surge. We're fearing a surge, and we're thinking somewhere around 4 months after folks or things start opening up again. As we look at unemployment, for every 1% increase in unemployment, there's a 1.6% increase in the suicide rate. During the last housing bubble, when it burst, studies related to foreclosure and evictions, or suicides related to foreclosures and evictions doubled during the last housing crisis. That if you're losing your home, that's a big deal, as you know. And also debt, that there is a relationship between severe debt and suicide deaths as well. So, we're not only talking the emotional and psychological stresses, but also those stresses around finances and around how you're going to provide for your family. That's something we really do. So we want to work with how do we work better with Job and Family, Ohio Department of Job and Family Services? How do we work better with job placement agencies, ADECO and those types of places? How do we make sure that folks are getting the care that they need? And I look at this, we got this a few weeks ago. I just wanted to share it with you. This young man, Brian Edwards, took his life on May 22nd. And he was one of, I think about 37% of folks leave a suicide note. And he was one that did. He actually wrote his obituary with it. So he actually wrote out what he wanted his obituary to read like. And this is the last 2 sentences that he wrote in his obituary. Unfortunately, the coronavirus decided to mess up my life. I couldn't work. I couldn't see my kids. I couldn't reach anyone at unemployment to help me. And many other issues in my personal life seemed unfixable. Mom, Dad, Bruce, Britt, BJ, and Ivory, I'll be watching you from afar. I didn't want to leave you. I tried to stay, but I had no choice. It's really, really sad. And it's something we're so scared about. This good-looking young man who had, 2 children, couldn't see his kids because of quarantine, and unemployment. So how is he going to provide for his family? It was something that he made a choice, and it's something we have to make sure that we're on top of, so that other families aren't feeling that. Um, and I have to close with something uplifting, going into the holiday weekend. So I leave you with a quote by Pee Wee Herman. Everyone I know has a big butt. Now, what I mean by that is all that kind of, sad news, especially that young man who passed away, but we can change things, but there can be some opportunities through COVID that we can actually build upon. We're having more open conversations. I'm seeing more articles and more conversations around mental health than I've ever seen before. So COVID has brought those, to help us understand and have those conversations. It's helped allow increased assessments at healthcare facilities. How understanding those conversations. How can we assess better? How can we also follow up with folks? Safety planning could be utilized at higher rates as we try to understand and look at this issue more holistically than just a mental health, but instead, how can we care for someone who has come in with a suicide attempt into the ER or even in someone's life? How do we utilize aftercare? I know that the department is pouring some work around their Zero Suicide Grant into facilities across the state around aftercare and making sure that we follow up with folks who have come in. Also, the state of Ohio. I know that we, along with PEGS Foundation and the Department of Mental Health and Addiction Services, are looking at crisis services like Georgia did in the Hurricane Katrina aftermath. When you get hit in the face by a 2x4, it causes you to maybe stumble back and say, wow, maybe we need to open our eyes here. And then, it has also opened up telehealth opportunities for treatment like never before. So reaching folks who have been 2 counties away from a provider now are able to get it in their home. Again, we have to do a better job of getting internet into people's homes so that they can take advantage of telehealth. And then also the state plan implementation. We have formed a group. The one thing that I was so depressed about when we were building this plan, there was a beautiful plan of another state. I don't want to disparage them. And I went and I visited that state, and the person who helped create this plan was managing this plan. And she said, yes, it's a great plan, but I'm buried 5 levels deep in my Department of Health, and no one is paying attention anymore. So we have to implement these strategies. We've got to measure them. We've got to evaluate them. And if need be, we need to change, some of the direction if we're seeing something is not working. So, that's my big but that I have at the end. But I would encourage some questions, and that's me when I pre-COVID. So I don't know, I don't know if you can see me or not, but I don't know, maybe I'm worse for the wear, it looks like, all dressed up being to what I am now. So any questions or anything?
Thank you so much, Tony. We greatly appreciate you sharing your expertise with us. And so Tony did mention that it is time for questions. And so we do encourage you to submit those using the question and answer panel at the bottom. So we'll be using those to ask him, and he will be able to respond to those verbally. But before we get to that, we want to make sure we have time to complete our knowledge check question. And so that is going to be popping up automatically for you, and so you should see that pop up. If you do not see that pop up, I ask you to look at the bottom on your Zoom toolbar at the very bottom. It should be next to or in the middle of the Q&A and chat features. You should see a new poll button pop up, and so if you do not see that, it is okay. We will be staying on after the question and answer session to give you a place to answer that. For people, if you are logged in only via phone, we will be staying on and read you the question as well as the responses. And so we will be staying and making sure that is available for you to complete that knowledge check. We know we've had some people unable to view the poll, so we will be able to make that available. We will show the slide after the question and answer session. And so just a few housekeeping things while people continue to answer the poll and submit their questions. We do encourage you to join us for future webinars. We do have our weekly summer series going on. So our next one is going to be taking place on July 2nd at 11 a.m. about resiliency, the art of living well, with Karen Vadino. And so we do encourage you every Thursday at 11 a.m. Eastern time to join us. And so you can find those sessions at go.osu.edu/OPC virtual. We do again want to mention our sponsors. We could not make this possible without them. And so again, we're going to put in their links into the chat so you can continue to reach out to them and use them as resources. They are some great information that they can provide. So we do encourage you to check out the Great Lakes PTTC, as well as the Ohio programs for campus safety and mental health. So at this time, we're going to begin asking questions. So Tony, I hope you're ready. And so now it is your time to continue to shine. Hope you got a quick 2-minute break there, be able to get some waters. We have some really great questions. And the first one we had come in is about volunteering. And so this person mentioned that they were United States Marine Corps veteran. And so just thinking about volunteering in general, how can people get involved volunteer-wise to help throughout the state in suicide prevention efforts?
So we have different opportunities that we have. We are going, we were supposed to do it this year, but we're looking at next year. We're going to have a statewide, campaign, but then we're also going to do some event. It's called All Walks of Life. We're literally taking we've collected 1,836 pairs of shoes, and we're going to take them across the state, and, different communities have signed up. And, if you would like to be part of that, we would love for you to, let us come out to your community and do that. Be with a coalition. If there's any way we can get you into a coalition setting, to help at the local level, these, are usually, 5 or 6, the coalition meetings have more than that. But, having folks at the local level, we're also doing some, we just got a grant to, and we're putting 5 veterans across the state to look specifically at veteran suicide. So the person just asked, contact us. There's a guy named Jason Hughes, served 22 years in the military, and he's our veteran liaison. He will be managing these 5 folks across the state on how we can better coordinate and better implement strategies around veterans in the state of Ohio. So yeah, please contact us, and we can put you in touch with coalitions. We can put you in touch with with Jason through veterans. And if you'd ever want any of our trainings, we're going to have QPR Train the Trainers coming up as soon as we're able to get in-person trainings going again. So it's normally, I think, $500, and we give it to you for free. So we just want to make sure that folks are out there again through the generous donation, generous funding from OMA. So thank you.
Thanks, Tony. We had a couple of questions come in, all kind of in the same vein. Would it be fair to believe that those who are using substances like heroin or other opioids don't care if they live or die? And can you also share a little bit more about whether intentional and unintentional suicides count in the same percentage, or how are those counted?
So we in our work with coroners, they actually list them separately, and the way that it's a bit of a consensus, although it does there's not like a general guidelines for folks. It's almost a coroner's opinion. Some coroners use something called psychological autopsy, so they actually go back, look at someone's history, where they put into a mental health facility. Did they have past mental health issues? Were they heavy drug users? Those types of things. So they do, some coroners look back and actually, and they also talk to family members to see, do you think this was intentional or unintentional? Did they talk about, not wanting to be here anymore? So it's really up to a coroner's judgment, and and then there are also some counties that they're a one-person part-time shop, and they don't have time to look at it in that deep of dive. So it's kind of all over the place, and that's what I'm hoping that our group will be able to develop maybe some guidelines with the coroner's input, and then also to measure this a little bit better to provide those better strategies. So I wish I had a better answer. I'm sorry.
Thanks, Tony, for answering the difficult question for going into that. This next question is about data. Do you have specific data on youth suicidal rates and mental health problems stemming from home environments versus peer influence?
It is, let me see. So look at my data here. So I know that there's a lot of talk around peer influence and bullying, and what we find are studies usually, there are some, it's a little bit all over the board. So I don't want to preface that bullying causes suicide. It's such a multi-factor type of death that we can't point back to one thing, one piece. Maybe they aren't getting the support at home. I just talked to a mother a few weeks ago who, if you looked at her son's death, it looked like bullying, because he was she said he marched to the beat of his own drummer, and he couldn't eat. People made fun of him, and 16-year-old boy, and that. But then there were also issues of he had been arrested. He had been had some brushes with the law, some problems at home as well. So it's a really tough question to answer. I do know that for adults, it's a little bit easier. We know that the intimate partner relationships are a factor in suicides among adults. So with youth, it's a little bit harder though, to try to separate out the peer versus the home life. But again, it kind of goes back to how we're building our youth to be resilient. How are we providing those protective factors? How are we doing that early prevention education in schools? So again, I wish there was a better answer, but we are at such a it's such an early field. It's really hard to get concrete data on a whole lot of this.
Thanks, Tony. Could you share if there's any data reflecting the differences in the method used to attempt or complete suicide by ethnicity or race, particularly among adolescents?
Yeah, so I actually just pulled this up today. So males use. It used to be females didn't use guns as much, and this just came. I just got this from the Department of Health today. That females now, it used to be females would use hanging, and now it is the female youth are actually using firearms as well. It's the number one method to die by suicide. So we do know that firearms, and again, it gets to urban communities as well. Firearms seems to be, again, it kind of crosses along all of those, all kinds of demographics. But firearms is the number one way of taking your life. attempts go back to, hanging and trying to overdose. But because a firearm is so lethal, the means, that's how you really, complete suicide. So firearms are the thing we have to watch out among all. And again, these young African American males that we're talking about, again, it goes back to firearms. Is the number one reason. We need to lock those guns up. We need to put locks on them. We need to make sure that they're put away safely in households in both urban and rural communities.
Thanks so much, Tony. A question similar to that is, you were mentioning about Black males and just the concerning data that we're seeing. And so some of the data you showed didn't include them. Is there a reason that some of the data may have omitted having that particular subset of population?
So the issue we got into was, like youth. Youth, it's the second, highest cause of death. The issue with listing out, a certain demographic of youth or a certain culture would be that, okay, do we then want to ignore or not list out LGBTQ youth, which also have higher rates of suicide? Do we want to, exclude, all of these different, so we tried to put it was a difficult discussion, and it was a good day that we just literally worked on number 4, on priority 4, simply for the fact, but we wanted to make sure that we didn't exclude anybody, so we did try to include as many folks as possible. Now, I do know that, in our work at Ohio Suicide Prevention Foundation, that we literally just started our coalitions and some other partners. In fact, Reggie, I saw, was on, and is going to be part of that group, Reggie Robinson, looking specifically at African-American suicide. How can we do a better job? So in the plan, it was more of an inclusive type of thing, so we wouldn't forget a group. But then, how can we then take a look at making sure that we do meet the needs and develop strategies for folks who, for African American, especially youth, having these really, really fast growing rates of suicide. And again, how do we get into and how do we make sure that communities talk about this? From, in my conversation with the African American community, it is it's a stigma to talk about, especially among young men, to talk about mental health. So how do we develop those champions to make sure? I'll be honest, me as a 50-some-year-old white guy going in, we need to develop those. Why would they listen to me? I don't understand the struggles. I don't understand. I have not been followed around a store, by a manager or something. Those are things that I can't know. So how do we develop those champions in communities? And that's what we're trying to do in this group, and also just look at it to develop those other strategies. And how do we reach this really, really fast-growing group around suicide?
Tony, we're past our time, but we do have a few more questions. Do you have a few more minutes to stick around with us, or do you need to go?
I got till 4.
Oh, perfect. Okay. Well, we certainly won't take that much time. We just have a handful more, but some of these I think are good questions. So one of them is, it seems a bit disingenuous on the part of those who rush to open things and are using the fear of suicides and mental health as perhaps an excuse to do that. And so, do you have any thoughts on that talking point of taking mental health and suicide and using it as the reason why we need to open things back up?
I think, and I don't know if this is, we have not developed a statement. So this is, remember that whole thing about this being a philosophical, what's my slide say here, this is my opinion. So I don't like that they're using mental health and suicide as opening things. Do I think, as we go along, is that going to be an issue if unemployment continues to rise? From our statistics and from our research, yeah, it will be. But at the same time, how could we instead develop strategies to, I think we had the 5 strategy for the state of Ohio. Reach out to 5 folks. How could we incorporate that more? We want to keep everybody safe. And it's hard, I'll be honest, it's hard not to get into those battles, especially when people in power contact me and ask about suicide rates among unemployment and what would this do. But I don't think, in my opinion, that we should be using suicide as a reason to stay open. Instead, we should develop strategies and ways that we actually are able to connect and reach out to folks. Again, aftercare or even using those aftercare specialists as someone who can reach out in the meantime. Hey, how are you doing? So that is, that's just my personal thoughts. And it's a hot political button right now. Sorry.
Thanks so much, Tony. Our next question is about the suicide plan and how often does it currently plan to be reviewed in the future?
We're going to measure. We meet every other month, and I would like it to be reviewed quarterly. We have a system where we're taking the data and putting it in so we can actually start looking at this as an implementation team. Valerie and I talked actually last week, maybe even earlier this week. How do we get an evaluator, a professional, someone who does evaluation for a living to look at this and to actually evaluate the plan. So it is something that we are going. We will look at the numbers every other month, and then quarterly. I would like to have some kind of report done so that we can see, and it almost be like a green, yellow, red type of system where green, we're doing great, yellow, we need some improvement, red, we're doing terrible. And that can help us with our measurement and moving forward. And then also, as COVID, we've had to adjust a little bit about even our priorities, our goals, into telehealth and crisis services and things like that we really hadn't talked about at all. We didn't talk about telehealth at all, really, outside of access. So that's something that we have to look at on the fly.
Since we are running a little bit over on time, we went ahead and provided the polling question to those who are unable to respond through the actual poll. You can provide your response in the chat and send it to just the panelists while we're wrapping up this Q&A. Tony, are you familiar with the phenomenon of deaths of despair? And if so, can you speak a little bit about that?
So deaths of despair is basically taking a look at all. So it's taking a look at overdoses and suicides. And it's interesting, this group that I referenced did a good study on deaths of despair, this Wellbeing Trust. And if you even look at the state of Ohio, it's kind of fascinating to look at our maps and see that the same the same parts of the state that were struggling with opiates are, have struggled with suicide. It's that access to care. So deaths of despair is, opiates, and it's those those issues of trying to ease pain, trying to their situation might not be great. There might be greater poverty. There might be, again, the access to care, and those deaths of despair kind of mirror each other in the States. So I hope that answers the question. It's basically suicides and overdoses.
Thank you, Tony. Our last question, we had two come in, but they were about things you mentioned towards the end about grants that you were mentioning, as well as programs such as the Walks of Life. Can you just reiterate access to those, and then maybe how to participate in those programs?
Yeah. So the All Walks of Life, just contact me or Michelle Price. And, we actually have a trailer someone has given to us, and we'll drive these 1,836 pairs of shoes out. I saw a display when I was in Budapest a few years ago of, there were bronze shoes alongside the river there in the middle of the city. And it was where folks who, folks who were killed by Nazis back in, and it was symbolizing those people because the Nazis shot them and just let their bodies float down the river. And it was very powerful. So, we wanted to do the same thing. And the interesting piece is people who have given their shoes to us are also folks who, it's their loved one who died by suicide, their shoes. So we're also going to have stories of people. We want to humanize it as well. So we're going to have people who have died by suicide and not talk about, how they did it, but instead, what kind of person were they? Who, what did they love to do? What was their, zest for life, and those types of pieces. So yeah, talk to me or Michelle, and, we will get that to you. It's going to happen, cross your fingers, next spring. And then other pieces, the coalition, learning the CDC strategies, that is an application process that we in Ohio Mouse and OU that we are working on together. And, it's open to coalitions and lost teens. That's another way that you can get involved. If you're a person who has lost someone to suicide, I encourage you to look to a lady named Denise Mine Graham in Lost Community Services. And it's a postvention group. So, that's how, call us or email me, and, I'll get you any information that you want as well. So.
Thank you so much, Tony. So that is all of the questions that we have. And so that concludes our webinar today, and as well as this week's featured speaker series. And so, Tony, thank you so much for being a home run, if you will, to wrap it up. And so we thank you for sharing your life and your expertise with us. And so thank you so much. And so that is the conclusion of today's webinar. We do have, if you weren't able to complete the polling question, myself as well as Cindy Clowner will be remaining on the line if you need to answer that via phone, if you logged in via phone and didn't log in via computer. So please continue to answer that if the polling option did not come up. So thank you so much, and we hope everyone has a wonderful holiday weekend and a great rest of your day.